Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. And today's topic is Understanding WHO Labor Care Guide LCG with question answer format. WHO LCG was introduced in 2020 and it was based on WHO 2018 recommendations. It is meant for all laboring women and you can care all laboring women can be taken care of by using this WHO LCG and especially for low risk women, whereas for high risk women, as per the high risk factor, we can have additional steps. For example, patient has got heart disease complicating pregnancy, then in that case we can have the additional steps apart from what has been given by in this labor care guide. It can be used at primary, secondary or tertiary care centers. When it is initiated at greater than or equal to 5 centimeters cervical dilatation because LCG is defining active phase of labor whenever cervical dilatation is greater than or equal to 5 centimeters. This inclusion is irrespective of parity and status of membranes. Who is credited with coining the terminologies latent phase and active phase of labor, first stage of labor, which we are using so frequently since last so many years. It was Friedman in 1954. What is Friedman? Friedman's curve is Friedman created a cervicograph. Cervicograph is a graphical representation of cervical dilatation against duration of labor in hours. He divided the first stage of labor into latent phase, considering that up to 3 centimeters, it is the latent phase of labor which is lasting for 8 to 10 hours, where there is no fixed rate of cervical dilatation. Active phase is cervical dilatation after 3 centimeters, where the rate of dilatation is around 1 centimeter per hour. Now, Friedman's curve is dividing this active phase into 3 components as stage of acceleration, maximum slope, and stage of deceleration. Philpott and Castle in 1972 provided us with alert and action lines. WHO in 1994 first introduced the first partograph, which we can call it as the original WHO partograph. This original WHO partograph had 5 components as baseline information, fetal condition, progress of labor by cervicograph, where up to 3 centimeters it was latent phase. Later on, there was an active phase, and alert and action lines were also included. Descent of the presenting part and uterine contractions. Maternal pulse, BP, temperature, and urine output, and drugs such as oxytocin, other drugs are or IV fluids. WHO modified this original partograph in 2000 and then onwards for since last 20 years we were using this modified WHO partograph, whereas in 2020 this labor care guide was introduced by WHO. Main difference between the original and modified WHO partograph is most important is removal of the latent phase. Active phase instead of 3 centimeters starting at 4 centimeters of cervical dilatation, and each box now had 30 minutes rather than 1 hour. Otherwise, it is in other respect it was same as the original partograph. Now, LCG has 7 sections, and what are the 7 sections? That is the likely question which can be asked to even students in the practical examination also. What are the 7 sections? So remember the 5 sections are same as we had in the modified or original WHO partograph, such as identification and information related to labor, baby's condition, mother's condition, progress of labor, and medication. 2 new sections which have been added are supportive care and decision making. Supportive care includes presence of companion, pain relief whenever required, providing oral fluids, and giving proper posture where the supine position is avoided. Now, mnemonic to remember all these 7 sections, I have prepared this as isn't baby mother protection my duty. I think this is our primary duty because whenever we care for a laboring woman, our main aim is to protect the baby as well as mother against all the possible complications. And that way you can remember this mnemonic as a mnemonic to remember these 7 sections. I is for information, S for supportive care, baby mother, P is for progress of labor, M is for medications, and D is for the decision making, which is a shared decision making where we are taking into account woman's opinion also along with the healthcare providers opinion. So isn't baby mother protection my duty is the mnemonic to remember these 7 sections in the labor care guide. There are certain similarities between this WHO partograph previous one and LCG. Similarities are cervical dilatation and descent is still plotted against time. Documentation of the 5 sections is same. Basic information, fetal condition, maternal parameters, progress of labor and drugs. These are same, though there are differences in the further details in the LCG. Now, single sheet or paper of both modified WHO partograph as well as LCG has total duration of 12 hours on it. So anytime labor is going beyond 12 hours, we need to use a separate or a new sheet. Differences between this modified WHO partograph and LCG main is we had alert and action line in the modified WHO partograph, whereas there is no such alert and action line. We have alerts as a separate column. Active phase starting at 4 centimeters. Here LCG, it is starting at 5 centimeters. That is important. Expected rate of cervical dilatation was fixed at as 1 centimeter per hour in the modified WHO partograph. Now this is the major change which is going to change the way we look at progress of labor for generations to come. And that is why this LCG is also called as next generation partograph. Here there is a separate alert for each centimeter of cervical dilatation. Second stage documentation is included is also another important change which was missing here, because in second stage with strong uterine contraction sometimes there is a change in the fetal condition. Fetal compromise can occur as well as descent is sometimes if it is not proper or as expected, that is also another feature which is important for the second stage monitoring. Supportive care is was not included, which is now documentation is included here. Alert was only for cervical dilatation. Alert line, action line only for dilatation, cervical. Whereas now we have alert almost defined alert is there for each parameter. Documentation, decisions were not documented in the previous modified WHO partograph, whereas now the documentation of shared decision is mandatory. What are the new parameters which are added in the LCG over modified WHO partograph? If we go section by section, we can see that for information, gravida was included in the previous modified WHO partograph, which has been removed now. LCG has now labor onset, whether the labor is spontaneous labor or induced labor as a new feature, and the risk factors also are added as a new factor in the baseline information, such as whether patient has anemia complicating pregnancy, preeclampsia. All these are to be mentioned at the top of LCG. Supportive care was not included in the modified WHO partograph, which whereas it has given a quite a lot of importance in the LCG, where there are 4 components: companion, pain relief, oral fluid intake, and posture. Where supine posture is considered as a alert or a bad feature, whereas patient is ambulant, mobile, or in lateral position, that needs to be documented and it is considered as a better posture. For the baby's monitoring, we had 3 parameters previously: fetal heart rate, amniotic fluid, and molding. There are 3 new additions to the baby's monitoring now: deceleration, where late deceleration is given as an alert; fetal position, where occipito posterior and occipito transverse position is given as an alert; Capute, a mark capute 3 plus capute is an alert. And molding 3 plus. Molding 3 plus, as you all know, grade 1 molding is, or 1 plus molding is when sutures are approximated. 2 is 2 plus molding is when sutures are overlapping, but there is a reducible overlap. And 3 plus molding is when there is a irreducible overlap. So 3 plus molding is considered as an alert. Whereas baseline fetal heart rate less than 110, greater than or equal to 160 is an alert. So each parameter has alert, that is one change, and there is an addition of 3 new parameters such as deceleration, fetal position, and capute. Now remaining section 4, 5, 6 almost these are same for the as for the modified WHO and LCG. Only difference is in alerts, that we have alerts for the maternal parameters such as pulse, BP, temperature, and urine examination. One difference here in the labor progress is though parameters are same: cervical dilatation, descent, and uterine contractions. Uterine contractions we were labeling it as strength, duration, and frequency of contractions, whereas strength has been removed from LCG because strength is subjective way of assessing the contractions. What is now documented is only frequency and duration. And uterine contractions, dilatation are also having alerts. Medications, there is no difference. Shared decision making is was not there, which is present in labor care guide, where there is a assessment column and plan column. For example, if companion, there are 3 possibilities. Y is companion needs present, that is good. D is patient is declining to have a companion, that is also okay. But if there is N, that is patient is not having companion but is wants a companion with her, then the plan will be to provide a companion. Companion will be of choice of the laboring woman, either a relative or a friend of that woman. We need to circle the parameter if it meets alert criteria. For example, in deceleration, if it is early or variable deceleration, it's okay. But if it is late deceleration, it needs to be circled, and preferably it should be circled by using a red pen. What is the approach used for implementation of LCG, or what approach has been advised by WHO? It is called as ARCP. That is the approach: assess, record, check the reference value or the alert column, and plan accordingly. As we can see here, A is for assessment, R is to record, C is to check the second column, vertical column is alert, to check whether the value is matching with the alert. If it is in the alert, then take necessary action such as dehydration, you start IV fluids, give pain relief if patient wants pain relief, change the posture from supine to the, ask the patient to be ambulant or mobile, and so on. So that will come under the P. So you can remember it as ARCP, and pictorially if you visualize this diagram in front of your eyes, I think it will help you to remember this approach: assess, record, check, plan. What are the alerts for each cervical dilatation by this LCG, or up to what duration we can wait safely for each centimeter of cervical dilatation by using labor care guide. So if it depends, it is changing from cervical dilatation centimeter to centimeter. For size 5 centimeters, we can wait safely for 5 centimeters. You can remember like that. Anytime the dilatation remains same for greater than or equal to 6 centimeters, 6 hours. I'm sorry. If it is greater than or equal to 6 hours, it is an alert. 6 centimeters, it is 5 hours. Greater than or equal to 5 hours, it is an alert. 7 centimeter, patient remains same for greater than or equal to 3 hours. 8 centimeters, patient remains same for greater than or equal to 2.5 hours, it is an alert. 9 centimeters, even patient remains 9 centimeters for 2 hours or more than 2 hours, it is an alert. So we need to remember this. that 5 centimeters alert starts at 6 hours. 6 centimeters alert starts at 5 hours and so on. So how I have remembered it is for 5, there we can exchange it that for 5 centimeters, we can wait for 6 hours, whereas for 6 centimeters, we can wait for 5 hours. So there can be, you can remember, you can exchange these with each other like that, 5 and 6 centimeters at hours. Here onwards, what I have remembered is 10 is the full dilatation, and for 7 centimeters, addition of the duration you can wait for should be 10. So it is 7 plus 3. Then add 0.5, 0.5. So 8 plus 2.5 is 10.5, and 9 plus 2 is 11. So 10, 10.5 and 11 is for 7, 8 and 9 centimeters, so that you keep on adding, so that these are the hours. Anytime 7 centimeters remaining same for 3 or more hours is an alert. 8 centimeters you can wait up to 2.5. 9 centimeters we can wait up to 2 hours, and later on it is an alert. This is the way I have remembered. But I think you will also have to find out a way to remember it. But or even if visually you see 6, 5, 3, 2.5, 2, and remember, it is well and good. Now, what must be the thought? What can be the reason why WHO has gone from this modified WHO partograph of 2002? After 20 years, why WHO is introducing this labor care guide? What is the rationale? Now, what was happening here was, here also WHO has given us a alert line. 4 hours later, there was a action line. We were supposed to do in the yellow zone necessary actions to be taken as advised by WHO, where transfer the woman to a higher center if necessary, start oxytocin if inadequate uterine contractions are there, reassess the woman and rule out CPD. That was supposed to be there. But what happened? Gradually, what happened all over the world, obstetricians stop giving importance to this action line. Action was taken prematurely. The labor dystocia or prolonged labor was diagnosed whenever the cervicograph crossed only the alert line, and decision to go proceed with cesarean section was taken in the yellow zone, which was not meant actually originally, and that resulted in increasing diagnosis, over diagnosis of dystocia, and increase in the number of unnecessary cesarean sections. So this fixed rate of 1 centimeter per hour is not true for each laboring woman. That was what the strong evidence was showing, and that is how the this WHO has come up with these limits for which we can wait safely. 5 centimeters we can wait, and if it is remaining same at the end of 6 hours or more, then it is an alert. So this is based on all the scientific emerging evidence where the laboring women were examined, who were having a good obstetric outcome, maternal as well as neonatal outcome. And then statistically it was found that as labor progresses, this duration, with the advancing cervical dilatation, this duration of safety should keep on reducing. Here it was same, that even if at 8 centimeters we were supposed to wait for 4 hours. 9 centimeters also we were supposed to wait for 4 hours, which is not correct scientifically. And that is why there was a need to change the alert, instead of having separate alert line, action line. What now LCG is giving is only single alerts only, and each alert separately for each centimeter of cervical dilatation based on statistical data. Whenever it crosses this limit, then again reassess, rule out CPD, transfer the woman, or give oxytocin. That starts at the end of this period. There is no need to go in any panic till this till these hours, for these many hours. This is a safe zone for us. So what it will result in the future for all the obstetricians is, it will reduce the unnecessary cesarean sections, especially cesarean sections which were done with the over diagnosis of labor dystocia. Advantages of labor care guide are, why it is known as a next generation partograph is, This is most important that it is based on the concept of respectful maternity care, where we are giving even importance to women's opinion also. There is a shared decision making. There is so much of significance given to the supportive care and labor companionship also. Pain relief has been given the same importance as this cervicograph or fetal heart rate monitoring. There are alerts for all the parameters. Second stage of monitoring is included. Shared decision making is there with its documentation, which was not there. Documentation is most important medico-legally also. Importance to supportive care, labor companionship, systematic approach, ARCP. I hope by this time you will be able to say it is assess, record, check, plan. Assess the findings, record on the LCG, check for alerts, accordingly plan the next action. There is a separate alert for each centimeter of cervical dilatation. Ultimately, what it provides is a individualized labor management and better management of labor dystocia. I have already prepared a video and uploaded it on labor dystocia controversies and conclusions. And all the conclusions are based on this 2020 labor care guide, which helps us in better understanding of labor dystocia or prolonged labor, and the way we diagnose and manage labor in future is absolutely going to change with the implementation of this labor care guide. This is the link for that video. This is the labor care guide single sheet. These are the 7 sections. Section 1, where we enter all the baseline information such as patient's name, spontaneous or induced labor, duration of active labor, duration of rupture of membranes, and most important, risk factor. Section 2 is related to the support, and as you can see, the second column gives us the alerts vertically like that for each parameter. Such as if for support there is a companion, we have 3 options. For companion, yes, no, or decline. So if it is yes or decline, it's okay. But if it is no, that means patient wants but there is no companion, we have to encircle it like that. Similarly, for the oral fluids, same. Y, D, and N. If it is N, patient is declining, it's okay. Patient is having, it's okay. But patient wants, but she is not getting, it is no. And it is a red alert, or it is a suggestive of an alert. So for each, there the N will be the alert. Posture, for posture, it will be supine. That is the alert. Whereas pain relief, same. Whether it is companion, oral fluids, or pain relief. For all these three, it is either Y, D, or N. Y is yes, D is patient doesn't want, so declines, and N is she wants but is not having, it will be an again alert. So this is about the supportive care. Section 3 is about baby. As we have already seen, there are 6 columns in that. Baseline fetal heart rate is there. Now see, these are the 12 hours horizontally, 4 stage. Whereas for the second stage, this is the part for second stage, where again 3 hours are included. As you can appreciate, every 30 minutes we are supposed to record the fetal heart, baseline fetal heart rate in the first stage, whereas every 15 minutes we need to record it in the second stage, as you can see here. Apart from that, even decelerations are there, and the late deceleration is an alert. With that, there is a caput is new addition. Molding is was there previously also. Amniotic fluid, if it is meconium 3 plus, thick meconium, or it is B is blood stain, then that is an alert. So there are total 6, and most important which has been added is position. So occipital as anterior position is good, but anytime it is an occipital posterior or occipital transverse position, it needs to be encircled. It is an alert. After that, section 4 is about the mother. For that also, for each parameter, though we can see it properly here, it is a hazy picture, but still for pulse, blood pressure, for urine examination, temperature, everything, there are alerts for the mother. Then next section we come to the progress of labor. Progress of labor, we have cervical dilatation starting from 5, and these are the alerts. So I will try to write. For 5 it is 6. For 6 it is 5. For 7 it is 3. For 8 it is 2.5. And for 9 it is 2. So these are the alerts. Now note that here, once the dilatation is complete, second stage is not having cervical dilatation. It has only descent. In the descent, it is per abdominal assessment of descent. As we know that this is the pubic symphysis and the fetal head above the finger blades of the fetal blade head above the pubic symphysis. So it is completely above the pubic symphysis. It will be 5/5. So we have to mark 5 in that case. On the other hand, it has entered and only it is 2/5 above the pubic symphysis, then we have to mark 2. And when it is completely, it has entered into the pelvis and it is not at all palpable per abdominally, it will be 0. So that is per abdominal. That is another difference I forgot to mention previously, that in the modified WHO partograph, it was this descent was according to the per vaginal examination as per the stations, but here it is per abdominal assessment. Next, after the progress, uterine contractions are also there. Then after that, there is a medication. Whether we are giving oxytocin, other drugs, or IV fluids, we need to mention here. Last is the shared decision making, where this is the assessment column and this is the plan column. So suppose in the assessment, for example, I am writing that patient is in supine position. That is the alert there. So that is the assessment. Patient remaining in supine position. So here the plan will be encourage for the patient to remain mobile. Mobile posture. So according to the whatever is the our examination finding, accordingly we need to, suppose the progress is normal, cervical dilatation, descent, uterine contractions, all the parameters are normal. Then here what we'll be writing in the assessment is normal. Normal progress. And here we will write in the plan, continue monitoring. So that is how this shared decision making has assessment and plan. Whereas for our implementation, what has been suggested by WHO, what approach has been suggested is assess, record, check, plan. So whatever we assess, we record here. All these columns we will be recording. This will be the as per the timing, and we will be recording here. Suppose we record here that there is a in the deceleration, it is a variable deceleration. It is okay. Early deceleration, it is okay. But late deceleration, red flag. Then we need to see whether there are hypertonic contractions, whether oxytocin is going on. We need to stop it. We need to change the maternal position and see whether it goes back to normal. Or we have to take the decision for cesarean section accordingly. That we will have to write here. So assess the parameters. 7 sections are there. Record at least hourly basis, and fetal heart rate will be every 30 minutes. Always check with second column, that is alert column. And then plan next action. That is also getting documented is most important. So that is how this is how you keep on filling it. Right? For this dilatation, we have to mark it as X, like that, cross. Whereas for the descent, we have to mark it as, say it is here, O, like that. That will be for descent, that this will be for the, suppose it is for this 6 centimeters. So next per vaginal examination, if it is showing 7 centimeters, then we have to mark like that. So that is how, and that will tell us whether it is coming in the alert or not. For 6, we know that for 5 hours we can wait, and here it is already going for 7. So that means it is progress is normal progress. That is the way it is to be filled, and that is the way it is to be documented. Thank you so much. These are the 3 important references I have used. Now, WHO Labor Care Guide Users Manual is a mandatory document each obstetrician should have at least as a soft copy. This WHO Next Generation Partograph. This LCG is also called as Next Generation Partograph. Revolutionary steps towards individualized labor care is important reference where the authors have discussed similarities and differences between the two, previous and the LCG. This modified WHO partograph in labor room is mainly the document which helps us to understand in detail about the previous modified WHO partograph. Thank you once again.